Good morning and welcome to the Florida Health Grand Rounds. We are going to be starting in just a few moments. Good morning. Welcome to the Florida Health Grand Rounds. We are excited today to welcome Dr. DeLeon and Claudia Blackburn. A few things to know before we get started. All of your phone lines are muted. Please enter your questions into the question box on your control panel. We will have time for a question and answer session at the end of the presentation. For your convenience, the slides for today's presentation can be downloaded. You can find the file located under the Handouts tab on the control panel on your screen. For those of you who would like to receive nursing continuation credits, please fill out the survey that will pop up at the end of the webinar. Make sure to enter your correct license number. And with that, we will begin with our introductions of our two seminar speakers today. Today, we welcome Dr. Jessica DeLeon, who is an assistant professor and an assistant in research at Florida State University's College of Medicine, with a dual appointment in the Division of Research and Graduate Programs at the Department of Family Medicine and Rural Health. She is a cultural anthropologist with over 20 years experience conducting qualitative research in a variety of community and healthcare settings. Dr. DeLeon's research focuses on the sociocultural aspects of health and healthcare among women, children, underserved populations, and racial and ethnic groups. Her professional experience includes medical anthropology, women's health, minority health, health disparities, and disaster preparedness and response. Jessica has published in anthropology and medical journals, including Family Medicine, Family Practice, Clinical and Translational Science, Maternal and Child Health Journal, Practicing Anthropology and Ethnicity in Health, and has presented her research at numerous state, national, and international conferences. She has received funding from the National Institutes of Health and Health Resources and Services Administration, the Agency for Healthcare Research and Quality, and the Department of Veterans Affairs. We also welcome Claudia Blackburn, who is a health officer at the Florida Department of Health in Leon County and assistant professor at Florida State University College of Medicine, Department of Behavioral Sciences and Social Medicine since June of 2014. A public health practitioner for over 40 years, Blackburn holds a BSN from the University of Connecticut, an MPH from the University of Texas School of Public Health, and was trained as a women's healthcare nurse practitioner and is a certified public manager. Currently, Blackburn is co-chair of the Department of Health Equity Program Council. She has been president of the Kansas Association of Local Health Departments and the Texas Association of Local Health Officials, and is a graduate of the Kansas Health Foundation Fellows Program, the Kansas Public Health Leadership Institute, and the National Public Health Leadership Institute. Blackburn has been the Public Health Accreditation Board site reviewer for 9 years and successfully shepherded the Sedgwick County Health Department and FDOH Leon through the accreditation process. She is also a member of the PHAB Accreditation Improvement Committee, providing feedback on the reaccreditation and process. Claudia served on the National Association of County and Health Officials, NACHO, board from 2013 to 2019, the Accreditation Preparation and Quality Improvement Work Group from 2010 to 2013, and the Public Health Informatics Work Group since 2011. Welcome to both of you. And with that, I would like to ask Dr. Blackburn to proceed.
Thanks, Robin, for that very nice introduction, and thanks for the promotion. I'm actually a nurse. I'm not a doctor, but I appreciate that recognition. I would like to thank Betsy Wood and Roseanne Scheck for assisting with this presentation. This was really a collective effort, and though they're not presenting, they are very active in the background. So I appreciate the opportunity to tell the story of the work we're doing in Leon County around collective impact, Black and white disparities in infant mortality, and women's experiences accessing prenatal care. I am the warm-up, so to speak, and will set the stage for the main act, Dr. DeLeon, who will share our research findings to date. For those of you who are not familiar with Leon County, we are located in the Big Bend region of the Florida Panhandle. We are home to the capital city and the only city in the county, that would be Tallahassee. Our population is 62% white, 31% Black, 6% Hispanic, and 1% other. And our Black population has long suffered from rates of infant mortality that are as much as 2.5 times the white rate. I would like to move to the next slide. There we go. So Roseanne Scheck, Program Administrator at the Leon County Health Department, longtime social worker and a member of our senior leadership team, submitted an application to City Match to participate in the Maternal Child Health Collective Impact Project as a way to build capacity for collective impact work in Leon County with a focus on maternal and child health priorities. City Match, for those of you not familiar, is a national organization of urban maternal and child health leaders that works towards strengthening public health leaders and organizations to promote equity and improve the health of urban women, children, and communities. So the application was accepted and we became part of the 2016-2019 City Match Collective Impact cohort. And this opportunity allowed us to be part of a learning community, including receiving technical support, training, but no funding. The purpose of the Collective Impact Learning Collaborative was to assist 10 local health departments to build capacity to implement collective impact strategies to address maternal child health priorities in their communities. And it was funded by HRSA's Bureau of Maternal Child Health. So 6 team members went to Washington, D.C. for training in January 2016. And so Roseanne and I attended, and then we had Dr. Ed Clark, who is a gun violence expert. He was with FAMU at the time. And then 2 Florida Department of Health maternal child health experts who worked in the Title V program, that Carol Scoggins and Chris Albers. While we were in DC, there was a significant blizzard that delayed us for a few days and our training was cut short, but we still had an enjoyable time in the snow. Okay, next slide, please. There we go. Okay, thank you. So what is collective impact? Collective impact is the commitment of a group of individuals from different sectors to a common agenda for solving a specific social problem using a structured form of collaboration. This approach goes hand in hand with our community health improvement planning process, and our hope was that it would give us new strategies to enhance our CHIP process. Next slide, please. So our partners came from Tallahassee Memorial Hospital, a local nonprofit hospital that serves the Big Bend area and beyond. They came from Florida State University, the Public Health and College of Medicine programs, Florida Agricultural and Mechanical University, the social work and public health programs, central office, Department of Health, also the Capital Area Healthy Start Coalition, Southside and Frenchtown Community Advisory Council. We had a nationally known private maternal child health consultant. We had an insurance company, Capital Health Plan, an FQHC, Bond Community Health Center. The school board was included, as well as Whole Child Leon. And partners were trained on collective impact, including how to create a common agenda, shared measurements, mutually reinforcing activities, and figure out how we would have continuous communication and backbone support. One of the key components of collective impact is the engagement of those affected by the issue, the people with lived experience. This is also the most difficult part. And for those of you that work with the community and do planning, you know that this is always the part that it takes extra time, extra effort, and there's an inclination to skip it. And we absolutely could not skip it here. This was really one of the main things that we had to focus on. Next slide, please. So during 2017, which was our second year, our collective impact group refined the focus to access to prenatal care. Another key component of the collective impact process is having a narrow, actionable focus, as reflected by our common agenda, which was increasing utilization rates of prenatal care to address health disparities and infant mortality. And we really spent the first year kind of pondering what that would be and got to that in December of 2016. This became our focus because the analysis of the prenatal care data showed a significant drop in early entry into prenatal care in 2016. As we dug deeper into the data, we learned that there were data issues from both hospitals that performed deliveries. An analysis of the data revealed that the process for collecting birth certificate elements was complex, and it appeared that there was a systemic problem that needed a solution. And anybody out there who's worked with maternal child health data and has really dug deep into their data has probably discovered the same thing, that there are inaccuracies in the data from time to time. So a small steering committee formed to address the birth certificate data issue, and we met monthly to work towards a resolution, which included training of the clerks and supervisors at both hospitals responsible for recording prenatal care visits on birth certificates. The training was conducted by the Department of Health Vital Statistics, and data quality improved significantly after the training. But by then, we had already identified other barriers to care that we wanted to address. So while the steering committee met frequently to deal with the data issue, the large collective impact group continued to meet quarterly. Next slide, please. As a side note, during the same period, Florida Perinatal Quality Collaborative developed a birth certificate accuracy pilot initiative where 9 hospitals worked on improving the accuracy of birth certificate information to 95%. Date of the first prenatal visit was among the most inaccurate items at around 70% accuracy. So that tells you that some of the historical data may not have been so accurate when it comes to prenatal care. In 2017, the pilot of 9 hospitals began with about an 88% accuracy rate. They raised that to 94%. In 2018, an additional 20 hospitals raised their rate from 92 to 95% accuracy. And then in 2019, a regional birth certificate improvement training program was created. And this training was done by Vital Statistics from the Department of Health. Next slide, please. So in year 3 or 2018 is when the steering committee looked at insurance benefits by provider. Getting this information was really difficult, but because we had persistent members, we were able to obtain this information. And what we learned is that what the insurance companies stated they provided did not match what some of the Healthy Start clients who were interviewed described. In February, the steering committee began looking at barriers to prenatal care, and we decided that we needed to hear from those affected, those with lived experience, and this led to the study that Dr. DeLeon is going to be presenting. Next slide, please. So before we move on to the nuts and to the meat and potatoes, so to speak, what did we learn from the collective impact process? So first of all, we learned that it is a slow and deliberative process. It requires continuous listening and consultation with all members. And to our team's credit, of the 10 collective impact teams that were trained by CityMatch, we were one of the 7 that crossed the finish line, and we continue to be active. Department of Health was the initial convener, Leon County Health Department, and that is a very comfortable role for any county health department. So that was also something that it was very appropriate for us to be doing what we were doing with collective impact. Another key to our success was the hiring of talented and organized interns. I believe we have had 3 so far. They were responsible for convening meetings, making sure we had minutes, and providing technical support. So that was really critical because, you know, we didn't get any funding for this. We came up with that funding from our own budget, and that made a huge difference in our ability to continue with this process. We were also fortunate to have a seasoned, knowledgeable team leader, Roseanne Scheck, who had the leadership skills, the partner relationships, and a focused approach to keep us moving forward. There were unexpected benefits as well. Relationships and trust were developed among community partners, and we created from this group a core group of members for our maternal child health community health improvement plan group. And we also identified Healthy Start as the natural lead for the maternal child health community health improvement planning work group. So those were all good things that came from this process. And I am now going to turn this over to Dr. DeLeon to tell you the rest of the story.
Thank you, Claudia. I'm going to see if I have control here. If you could pass to the next slide. Okay, so I'm going to talk today about the qualitative research that was developed out of the background that Claudia just provided from the Collective Impact Group. So we know that early and consistent prenatal care, right, is vital and key in achieving positive infant health outcomes. But a lot of research shows there's still many barriers that increase the likelihood of women getting late care or no prenatal care at all. And these are, you know, health behaviors of the individual as well as socioeconomic status, all those social determinants of health. Okay, next slide. So the significances are in our study. We wanted to learn from people's real experiences, and this was part of the Collective Impact mandate and mission, right? To learn from real people, women's lived experiences of their, to get a real patient-centered perspective. So we wanted to explore the social determinants of health that impact prenatal care access and use. And we're hoping that what we learn can lead to programmatic changes, policy changes, changes in the health system and health settings that can improve access and more early entrance into care. Next slide. So data collection, we did 2 forms of data collection. The main was a 1-hour semi-structured telephone interview. So these were all done over the phone. We also did a brief demographic survey so that we could learn a little bit about the subjects and a little bit about their background. Our interview questions started with a large opening question where we asked people to really talk about the story of their prenatal care experience. And we left that purposely very large and open-ended so people could really start the conversation in a place that they felt was important, right? So tell me your story the way you want to tell it, what's important to you. We asked specific questions on barriers and challenges and facilitators to care, as well as views on what would be the ideal prenatal care program people would want to see. And we asked that question a lot with the caveat, you know, we might not be able to meet all your desires, but we really want to hear people talk about what they would want without any barriers in mind, if it could be the perfect situation for them. We had colleagues and students assist with data summaries, so we transcribed the interviews and are using NVivo for analysis, which is qualitative analysis software. Next slide. Our analysis included, because we did a mixed methods, 2 techniques. So for the survey data, we're just doing descriptive statistics, frequencies, things like that, using SPSS. And like I said, for the interview data, we're doing qualitative analysis with NVivo. 2 kinds of coding. So coding is, putting your kind of meaning and signposts into the data, of like starting the analysis process of getting topics, themes, categories together. I came in with 2 models that I'm going to talk about. So 2 theoretical models that I wanted to use in analysis, but we're also doing open coding. So under these larger kind of model theoretical umbrellas, I'm letting data arise from the analysis arise from the data, which is called grounded theory, right? The idea of your meaning is grounded in the words that people say. And we're going to, learn to discover themes and concepts through kind of constant comparison, very iterative process where you're constantly learning, going back and forth, comparing with previous data. Next slide. So 2 models, as I said, were used in the analysis. The first, and I'm sure you're all familiar with this, is a social ecological model. So this is looking at ways in the individuals interact with their environment, relationships at different levels. So you have the individual in the center here, but also we have an interpersonal level, so your peers, family, in healthcare world, your providers. Then the organizational level, which is like a larger level, looking at your kind of employment areas, healthcare systems, larger organizations that individuals interact with. And we go to the community and the policy level. For our analysis, we're basically staying at these first 3, individual, interpersonal, and organizational. Next slide. The other model I'm looking at, in the organizational level, a big thing we wanted to look at, and was one of our goals going in, was looking at access to prenatal care. So we used a model from Pinchansky and Thomas that looks at 5 dimensions of access. Availability, which is your availability of your providers. So part of it is the volume of physicians, how many healthcare services are in your area, things like that. Accessibility is the second dimension, and that's looking at the location, geographic ease of getting to your providers. We also added, as you will see, online resources and an online virtual world as part of this accessibility. So not a physical location, but a virtual electronic location. Accommodation is the makeup of the healthcare organization, also called advocacy. So the way that the service is delivered, designed, the healthcare setting, all those kind of setting focused dimensions. The 4th dimension of access under this model is affordability, and that's just as you would think, the financial ability to pay for your services, the value you're getting for them, the reasonable prices you're paying for what you're getting. And then acceptability, which is the attitudes of those who receive care about their healthcare providers or healthcare settings. Next slide. So a little bit of results. So now we're going to go into kind of the meat and potatoes. So we've talked to 9 individuals so far. So we're kind of in the midst of our data collection. There's a little bit of demographics from our survey. Age range was 23 to 42 years, mean age of 31.4. We're talking to African American, Black, and Caucasian women. So our breakdown right now is mostly white, 66%, 67% white, 2 African American women, and then 1 biracial woman. Our CUP informants have a high level of education, which is part of being in our county, part of being in Leon County. Because we are the most educated county, I believe, in the state. So that is not unusual, but we are going to work in the future recruitment to balance that a little bit. Marital status, most of our folks were married. And again, you'll see here also a high level of income. So we're going to, over recruit and really try to balance that out with a more broad range of economic status. And then insurance status, most had employer-based, as well as 1 private and 1 person on Medicaid. So now we're going to look at some of these models we talked about and some of the real results that we learned from women. So first thing we're going to talk about, as I said, is this kind of individual level, this first level, which includes patients themselves as well as their providers. And we're looking at barriers and facilitators. So what makes it difficult or hard to access or use care, what makes it easier, right? And facilitates that use. So as far as individual barriers, the first thing we see is kind of care barriers for women. So they feel a pressure to follow the guidelines they're giving, and they appreciate the information and the knowledge of what to do, but there was kind of a burden on them to feel to comply exactly to all these guidelines they were giving. Some people talked about the feeling of burdening clinical staff if they asked too many questions. They felt like I shouldn't, I asked too much, I need to stop doing that. They also talked about, this is for people that have pretty easy or, low risk pregnancies, that the complacency comes from visits that are always the same. Oh, you're doing fine, you're doing great, see you next week. Kind of makes them seem like, why am I coming here? Why am I paying for this, right? If everything's always fine. So it's kind of a nice problem to have. Other care barriers include self-empowerment or self-advocacy. People sometimes felt it was difficult to advocate for themselves as a patient. And then pregnancy itself, right? So it's a time that's scary, anxiety causing on any level, never mind with other stresses in life, the world we're living in right now, and especially for first-time mothers. So people that were pregnant for the first time that really had no experience, it was more stressful and more anxiety causing for them. Providers also might face their own barriers. So our informants talked about feeling their providers are kind of burnt out, that they've been doing this a long time, they're not really hearing anything new, and it kind of leads to this, compassion fatigue or kind of a repetitiveness, that they don't feel they're like fresh in their care anymore. Looking at the next level, so we're going up to this interpersonal kind of network peer family level. So we're looking at family, peers, and social network barriers. We're going to look at the negative first. Some people did talk about just a general lack of social support. Mothers that are on their own, people that are new to the community really don't have the support that they feel they need. Some folks talk about relationship issues. So this would be with either other romantic partners or with the fathers of their babies. That in times of pregnancy, relationships end, relationships stress increases in fighting and things like that. So kind of romantic relationship problems. Some people talked about their father of their child not being present at all or not being really helpful during their pregnancy. And then gender role vulnerability. So the idea of being financially dependent. So some folks that had to leave positions, leave their jobs, felt the kind of a vulnerability being dependent on someone else's salary. For some people, this was the first time that had happened to them in their life, so they were kind of stressed about it. And then pregnancy itself, right, is talked about as making women more vulnerable, and put in the context of a society where violence against women, crime is something that we do worry about kind of on a daily basis as females. But pregnancy and having young children even more so makes that just more of a problem, right? Having, you're slower, you can't react, you're putting kids in car seats, all these things that kind of separate you from being cautious about your own safety. So looking at some more of the interpersonal level, but now we're talking about facilitators, the things that people said help them. So one was really the variety of the levels, types, and structure of support. So people talked about support also like from their spouses and their partners, the fathers of their children, all the way to a larger community, and that's a community of mothers in a larger sense, but also their general community of their city, of their neighborhood. And people really talked about having support along those trajectories and the importance of all of them. And I was really interested to see how big those kind of connections went, right? It's not just with family and friends, but really with a larger community. Having experienced and knowledgeable mothers in your network was helpful. People that could give you advice, tell you about experiences. And also sometimes people had networks that include peers with professional experience. So there's someone in the healthcare field, someone in the social work field that referred them to community services, so they got extra information by the kind of people that were in the network. Big thing people talked about was peer support groups, the desire for them, the importance of them. And this is, I think, one of the most important bullets, was said beautifully by one person. They want to share experiences, ask questions, and get advice. And that's really what was seen as like what a support group can do for people. They want to include physicians for medical questions. So they want peers, but also professionals. Breastfeeding topics was one that was talked about, as well as general health and wellness. Postpartum depression was brought up as something people want more info about and really want to be more upfront about talking about. And then we did talk about the need, as some person brought up, a support group for African American Black women specifically, as a way to share stories, backgrounds, but also have that shared experience, shared culture, shared family structure that can make them feel they have a safe place to share their thoughts and opinions. Looking at patient-provider communication facilitators. So here's another part of kind of that network, you and your provider. So people wanted their providers to answer questions thoughtfully, thoroughly, with detail, with elaboration. Don't give not a one-word, not a two-word answer, without dumbing down answers. So people wanted to hear the real response that they would give anyone else. And, you know, we could always ask more questions as well. You know, people told me, but don't give me kind of a simple answer to start. They want providers to answer questions like they're the most important questions they've ever heard, because to our moms, they are the most important questions, right, ever asked for them. And then be supportive and encouraging of people asking questions. So they don't want to feel like I'm, you know, being a pain or I'm burdening people if I ask my provider questions. They wanted providers to both teach and learn. So teach without waiting for patients to ask questions, right? So especially the first-time mothers, I heard things like, I don't even know what to ask. I don't know what I don't know. So just tell me, right? Don't wait for me to ask. If there's something you think I should know, just tell me up front. Tell me and teach about medical issues, right, within your profession. And don't stop teaching. Don't assume patients know what you're going to say. Don't assume that experience from past pregnancies means I know everything. Just always keep teaching. And then learn from patients as well. So the other side of it, learn from your patients via detailed questions from them. And some more facilitators in this patient-provider relationship. So looking at things like rapport and trust. So they wanted their providers not to be, right? Don't be condescending. Don't be cursory. Again, these kind of quick one-word responses. Don't provide empty reassurance. So we heard from some people, they would hear things like, oh, you're fine, you're okay. Don't worry about those kinds of things. And I think from providers, they're thinking they're putting patients at ease by saying, you know, if I'm not worried, you don't have to be worried. But really, that doesn't help when you have an interior concern or a problem. You really want an answer to that concern, not just like, don't worry about it, it's fine. And don't make people feel rushed. And this is difficult because we know clinic environments are, you know, have a heavy patient load. You also have, you know, 5, 10, 15 minutes per patient. So that's difficult, and really more than just provider behavior, it's the setting barrier as well. So what should they do? We want our providers to be, we're told, respectful, supportive, compassionate, and caring, number one. And people, whatever barriers people had, they always felt like their providers were caring and cared about their outcomes, just didn't always have the time to show it, right? Concerned about what concerns the patients. Again, none of that, it's okay, don't worry about it. Follow up patient concerns. So if you said you're gonna follow up, get back to them, do so. And then see pregnancy experiences from the patient's perspective. And that comes back to that kind of fatigue of providers. Just because you've done this a million times, could be the first time, or it's super important to every mother, every pregnancy. So look at it from her perspective. All right, now we're going up to this next level. So this organizational level, the healthcare settings and systems. So this is actually really looking at the patients themselves. So people told us about barriers that are work and employment related. So again, I talked earlier about one of our informants needing to leave a position and rely on her baby's father's income. So people had to leave work because they couldn't, you know, do the kind of work they were doing. They had to decrease work schedules because of problems with their pregnancy. People did talk about discrimination at work from pregnancy, from jobs going to other people, from one person that was actually let go and had to fight that decision. And again, some negative impacts of having to take lower paying jobs, work less hours, things like that, impacting your financial stability. Now we're going to look a little bit at this. So this is back to that Penn-Chansey model, right? Looking at these different levels of access. So first we're going to talk about accessibility. So some barriers. And this is, again, kind of unavoidable, but things that impact patients. So practices dividing while you're a patient. So things happening around you at your healthcare setting that, of course, is going to affect your care. Physical location problems. So one person talked about difficulties parking because of healthcare setting that is in a large hospital. So everyone for the hospital, all the professional offices, everyone parks in one large parking garage. So it's always super crowded. It's hard for pregnant women to walk if they're parked far away, right? And there's also a danger aspect, actually. The providers, like I said, at a busy hospital, so battling the whole rest of the healthcare system when you're trying to, you know, get to your appointment. And then transportation problems, right? We have public transportation here that's not, the best. It's not a large, super large urban area, and especially difficult for our rural population. Prenatal care really for this area in our rural counties is located here in Tallahassee. So people need to come here for care. So traveling into town, traveling within Tallahassee. So transportation is a huge barrier for all kinds of healthcare opportunities for our rural population. As far as resources, so this is something I mentioned earlier, we did see that online resources could really be a real facilitator for access. And this was, most people at least have smartphones now, we're looking for like chat rooms where they could get advice from folks at any time of day, right? So that's the wonderful thing about the virtual world, as well as telemedicine. So people were interested in telemedicine platforms to talk to their providers. Looking at our next access dimension, availability. So how can, ratio of providers to patients, how available are your providers? So one thing we saw as far as a barrier was limited resources. So this is within clinics, and as I mentioned, busy offices with time-constrained providers and staff seeing a lot of patients daily. There's relatively limited local providers available here in our community. So there is a care shortage in our city, as well as, you can imagine even more exacerbated in our surrounding rural counties. Strained resources and overbooked services. So people talk about, oh, I heard about a hospital tour, but I was never able to get in time because they're booked months in advance. By the time I heard about it, it was already too late, kind of thing. Initiating care with new providers is difficult. So if people want to change providers for whatever reason, they create long delays in getting that initial appointment. Again, something that when you're pregnant, right, you don't have time to just wait. Patients fear changing providers for this reason. And I heard from one person, she had wanted to change providers, was not happy in her present situation, but had the fear of what would happen if she tried to go elsewhere and would be kind of locked out, right, of getting in care somewhere else. Main provider being unavailable is something we heard a lot. And that was one woman talked about when I was in the hospital, I never saw my main provider at all in the time I was there. But especially what we heard a lot was like during delivery. And patients know this going in, right? You have your main provider, but know that they won't necessarily be the one with you at delivery, but everyone hopes that they are, right? And it seems pretty common that they're not. So people either had someone totally different, a provider that they knew, but were not like super comfortable with or very, had worked with a lot, or their main provider was only there for the very last bit of their delivery, right, at the very end. Again, changing providers mid-pregnancy, people were scared to do that, right? But also that sometimes happened around them. Oh, that person left, people retired, new people come. So often people's providers were changed without their desire to do so, right? This kind of happened. Then continuity of care was a problem. So this is rotating providers within clinics where you're seeing all kinds of different people. Patients talked about having to say the same story to different people. Same thing I said 2 weeks ago, because I'm talking to a new person now, right? As well as difficulties and delays in getting appointments at all. So what would make this better, right? So availability facilitators, more resources and services, of course, right? We need more tours, more classes, more outreach to people. In the clinic, people wanted to at least sometime get to a live person. They understand, the need of phone trees, but a constant recordings was a barrier for folks. So they really wanted to talk to real people and try to reduce the waiting times for appointments. Patient-provider interactions, they wanted to at least the providers, if possible, to check often during birthing. So even if they can't be there all the time, people would appreciate if they could at least come by, every once in a while and see how their patients are doing. And then spend more time with patients. And again, this is something that is kind of setting and system dependent and difficult, because within these environments, often people don't have more than a few minutes, right, per patient, per visit. And then pregnancy. So this was interesting. One woman talked about she feels that her access actually has increased while pregnant because people feel, the time frame barrier that she is facing, that she needs care now and quickly. So she feels she's been able to have increased access when pregnant that will fall away the minute she's not anymore, right? So she's actually felt like this kind of opened an access door for her because people feel the need to find her services quickly. So some more facilitators. People talked about wanting healthcare teams, collaborations, and referrals. So they wanted a team of consistent, regular providers that they get to know well, that they see often, that will streamline their care. Again, none of this repeating what you said to the last person. This person really gets to know you in a deeper level, or at least a few people, right? They acknowledge it maybe couldn't be just one person, but small focused teams of care providers. They did like, and this is kind of the opposite of the burden of being in a big facility with a lot of providers and a lot of other services, maybe is a burden as far as accessibility, but increased availability, right? Because things are available right there in the same building, from primary care to specialist care. Your OB could be right there. So that actually helped as well with availability facilitator. Referrals to social services. So if people want the referrals outside of just a healthcare or clinical environment to social services like Healthy Start, they wanted their patients to, to be encouraged to use other resources, right? And for providers to know about resources and services available in the community, in other healthcare facilities that they could offer their patients as well, and really encourage the use of other kinds of outside sources. And then they wanted their providers to give specialists referrals, right, for certain concerns and conditions that would be better met with another type of provider. Okay, now we're looking at acceptability. So this is people's kind of perceptions about their providers in their healthcare settings. One thing we heard about, and I would call this kind of the culture of care. So when you're in a giving birth, the kind of environment and culture that your healthcare facility or setting has. So people talked about baby-friendly care, which is, a national initiative to increase bonding, breastfeeding in hospital by having the baby, in the room always early, with the moms, which actually was super liked by people, right? They thought that was a great idea, but at times I was told it was just too much for exhausted moms, right? They never felt they got a moment to rest. The increased stress of like, oh, I'm on 100%, even though I just, just delivered. I'm physically weak, exhausted. So they needed actually a little bit of little time, right? A little time there to rest a little bit and get a little bit of help, at least at the beginning. So that instant focus on mom and baby only burdened people a little bit. And then people talked about guidelines being too finite or constricting. These are things like breastfeeding guidelines, for example. So they talked about, the hourly, do this on this hour, sleep for 3 hours, feed at this time, was not feasible in the real world, was causing them anxiety and put pressure on them to be, people said, I feel like I have to be the perfect mother, right? And to stick to, if I'm not sticking to these guidelines, I'm not fulfilling that. And they wanted really like more spectrum of guidelines. So something not so finite, so concrete, so quantitative that they feel if I'm not hitting those exact points, I'm making mistakes. There was also some advice from family and friends that didn't comply with what the guidelines were. So people felt that back and forth, do I listen to my mom? Do I listen to what my doctor said, right? And then mental health services was definitely needed. So one barrier, I called it a lax conduct of mental health depression screens. So what I heard was a clinic who was doing depression screening on all their pregnant women, which is fantastic. But she felt when it was being given to her, it was almost like the provider expected her to say no to all the responses. And she's like, I would have said no, so there wasn't a problem for me. But I felt if I had had a mental health or depression issue I wanted to talk about, I was almost being primed and shown that it wasn't okay to talk about that, right? I'm ready to check, she's fine. So that's going to make people kind of shut down. So like, if you're going to give a depression screen, do it for real, right? And really let the people answer for themselves, give them time to really tell the truth or, answer completely before you kind of check a box for them. On the other side was clinics or facilities that don't address mental health at all as being a real barrier. That is part and parcel. People wanted mental health and physical health care together. Affordability. So looking at the ability to pay and the value that you get for your dollar. So some barriers, we talked to people with different insurance status as we saw. There was barriers for every type of insurance level, no matter what you had, there are barriers associated. So for our insured informants was frequent and significant co-pays. And these were about $40 for most folks, but when you're doing that, every week, sometimes more, if there was complications, it really adds up at a time where people are feeling financially constrained anyway. There were limitations on care and services covered. So, your insurance will pay for certain things or certain tests, but maybe not multiple. People talked about their having fewer ultrasounds that they felt they needed because their insurance would not pay for it. For people on Medicaid, of course, it's limited access of Medicaid providers and facilities. So the idea of like, it increases our access, you think, but then I can't get an appointment. People don't pick up their phone. People don't call me back. And for uninsured folks, of course, paying out of pocket for services. And one woman talked about paying up to $1,000 at one time for an emergency care visit. So that's the other deal, right, of not having a steady provider, often when you're uninsured, looking to the ER for services and care and the costs, associated with that. Income and unemployment barriers included one-income families, and I talked about that a little earlier, and as well as fluctuating employment and insurance status. So as I said earlier, people's employment status would change sometimes with pregnancy, themselves and or their spouses or partners, and insurance fluctuates as well, right? You lose one insurance, you have to buy something else. So one person talked about losing their spouse's employer base and having to start purchasing their own private insurance. And then people talked about limiting their own use of services. I really can't afford it. I can't afford that copay, so I'm just going to skip that care. So really limiting their own care because of concerns of cost. Facilitators was financial and economic support. Not surprising, but that could come from all kinds of ways, from friends, families, peers, all the way to more social service, community-oriented assistance. Reduction in per visit insurance copays. And one woman did talk about a clinic working with her to reduce her copay so that she could have as many visits as she really needed. And then, of course, things that are free, right? For birthing classes, breastfeeding classes, anything that can be given for no charge. Accommodation barriers. So this is looking at kind of the whole kind of organizational setting, the services. Looked at 3 different things. So one was clinic environments. And as I said earlier, these kind of hectic clinic environments, changes in providers. People talk about disorganized offices where, lab results would be lost or never entered. Provider and staff burnout. And as I said, compassion fatigue is a word one of our informants used that I thought was just an interesting and fascinating phrase. Linkages to care and care transitions. So again, this prenatal care needs as much as not being able to get what you need within your own healthcare system, as well as people talked about an immediate disconnect with care after birth. So while pregnant, prenatal care, you're being seen a lot, you're really being taken care of in a high level. They felt that the minute they delivered, that care kind of dropped off, immediately focused on the child only, and left them kind of in a lurch of, a lack of a better way to say it. I was taking care of it, getting my questions answered, and all of a sudden, like, all that disappeared pretty immediately. So what about the good side? Some facilitators, and this I think is really one of the biggest themes we saw, is to address patient diversity, varying needs and preferences. So women are very different, have a lot of different ideas and desires of what they want for prenatal care. From one woman I talked to took her all her prenatal care at home naturally, didn't see a customary provider at all the way up to people that had really a lot of complications. We're seeing providers of all different kinds all the time. So diversity in the patients, right? So patients' personality type to begin with. Some people want an anonymous chat room because I'm too shy to talk in public. Other people are like, oh no, I want to be, in that face-to-face group and really get that support. So people's needs, personality-wise, varied greatly. First-time versus experienced mothers is something we heard a lot. So first-time moms really need a greater focus and care and instruction. They don't know what they're doing. They've never done any of this before. They're super fearful and really need extra focus compared to experienced mom, right, that has a little bit more knowledge coming in. The diversity of pregnancy experiences, and this could be across women, but also for women over multiple pregnancies. My first pregnancy was like so difficult, but now everything's really easy, right? So you really have to like think of what's happening for people in the moment and at their current situation. And then people really liked a diversity of providers, from traditional kind of OBs and nurses, but also midwives and doulas, but also other kind of care for other symptoms and problems during pregnancy. So physical therapists to deal with pain and fatigue, mental health counselors for kind of the stress and anxiety caused at this time. Different kind of providers with different kinds of knowledge systems, care interactions, and then definitely a balance of medical and non-medical needs people wanted, from the physical kind of clinical help, but also for mental health, stress, emotional support as well. And then of course they would help to see gender and racial diversity among providers. So people did talk about, I feel more comfortable seeing a woman who can really relate to what I'm going through. I feel more comfortable seeing someone that kind of looks like me. So that kind of racial diversity, so people can have a provider-patient relationship that feels comfortable to them. And then diversity in patient care, right? Again, both physical and mental health care combined. They don't want either one deleted or left off. You always want to address people's stress and anxiety at this time. Natural and non-invasive care as well. So things like massage, physical therapy, relaxation techniques, herbal medicines, other things that could help in a kind of more naturalistic way. Help patients fulfill their birthing desires. So people really wanted providers that listen to their birthing plans and what they wanted for their labor and delivery, and help them reach that goal, balanced with, of course, their safety and their baby's safety and medical knowledge. But someone that really works as a partner with patients to get them to that place that they want to get to when they're going to give birth. Care for mothers as well as babies. So, this idea that moms are going through a lot too, and we have to, kind of focus on that as well. And people wanted tailored care that's evidence-based. So one woman talked about her provider often doing research, kind of on PubMed research, things like that, to learn more that would help her, right? She said that was really important to her, to know that the provider was looking deeper to help her more. Resources and services. So this is kind of our last bit of kind of organizational accommodation facilitators. So support groups came up often. The type and structure of those groups varied of what people would want, but the idea of having support groups was important to quite a few people. Like I said, some people wanted something anonymous where they can ask whatever questions they wanted without feeling that I'm asking something silly or I should know this. They could just feel comfortable to say whatever they want. Wanted women with shared pre-existing medical issues, so people that are like them, right, in their healthcare and their healthcare needs and are facing some of the same situations, to have support groups specifically for certain medical conditions. Non-physician peer networks, so there was a mixture of people that wanted either just peers alone, just physicians alone. Some people talked about just having kind of a panel of providers that answer questions, or something mixed, half and half, right, with peers, with providers present to answer medical questions as well. People like the idea of a quick online chat, just ask a quick question and get a quick response from other mothers, and that was especially important for women that aren't connected with other mothers here in their community for whatever reason. And these could help women connect that don't have the social support that they feel they need. Or like I said, one of our informants was new to the community, so she didn't really know anybody here, and these kind of formal support net groups could help her, right, connect with folks in a way that she's not able to do easily. There was a real need for an increased focus on fathers. There was a real, and this I think I heard very often, that fathers are just even kind of left out, even if they're physically present. So even when I bring my spouse or the father of my child to the appointment, providers talk to me, they don't ask him anything, they don't even look at him hardly, right? So they needed to be included more and more engaged when they're there with with the mothers, but also services just for fathers, father support groups, father tours of the hospital, parenting groups just for fathers as well. And then, of course, mental health and stress, right? This is really important. So people wanted help and information on postpartum depression. They wanted depression screening done, and looked for maybe group therapy for people that are having a little bit more difficult time, group therapy with mothers and professional counselors. So women that are going through things similar to them, as well as professional therapists and counselors to guide those sessions. And last, I wanted information on a couple different things. One was what to expect throughout the pregnancy. So kind of a month-to-month guide, week-to-week, this is what's going to happen, this is what to expect, this is what you should be doing, as well as a comprehensive view of your entire pregnancy. This is kind of like a big picture and then like a step-by-step guide underneath that. Wanted information on like milestone visits at the clinic, what's coming up, what I should be doing, what I should be bringing, how to prepare before I get there, right? So people are like, oh, I should have done this and that at this visit, but I didn't really know that until it was too late, till I was there. Dealing with the physical symptoms of pregnancy, so things like nausea, backache, pain, other kind of pain issues was something I heard quite a bit. So dealing with the physical symptoms of pregnancy was something people wanted more information on, as well as the end of pregnancy and after delivery. So again, this idea of like, I knew a lot to that point and then things kind of fell off for me. So about labor, birth, what happens after you bring your babies home, breastfeeding, tips and tricks and hints, parenting skills, and then again, really focus on postpartum depression and checking in on women, right, post delivery to see how they're doing in their emotional status. And that is it.
Okay, thank you both very much for that wonderful seminar. We appreciate you taking time today to present to us. We do have a few questions here as we wrap up the talk, and we'll ask questions as time permits. So the first question we have is, you mentioned that there's online access, for example, chat rooms, telemedicine, and online groups. Are these types of services and access currently available? And can you tell us a little bit more about how to find these online services?
Yeah, okay. What I'm presenting is desires of people. So I know telemedicine, of course, has been a big push on all settings because of, COVID for one. I have heard, and this is not so much in this environment, but for primary care, I know, and I'm sure it's probably similar, that telemedicine is difficult because often you need to see a provider in person first before you go to telemedicine. So if you're looking for a new provider or want to switch providers, that's a barrier actually. So telemedicine is not like an easy answer to everything. But yeah, these were really talking about what people wanted. Claudia, of course, jump in if you know of other services that are things like online support chat rooms and things like that.
I don't, but we'll take this information to the planning phase, and we'll
Right.
be doing an assessment to see what we have that can respond to these desires. We're not there yet, so.
Yes, and we're really a goal of using some of these models as well to really come up with results that are very applicable and can really be applied to real implementation and creation of programs and services. So the individual kind of sociological models, what you can talk about levels of implementation, how to impact people at different levels from themselves to their communities, as well as these kind of dimensions of access as places to focus on. So yeah, we really try to do analysis that was like, now we could pick up and do something with it.
Okay, great, thank you. Were any of your participants tobacco users? And did you address tobacco or other substance use in the course of your interviews?
I did not specifically, so I don't know if they were. I don't know if they were, and I did not specifically ask about that for sure. I let people tell me what they wanted to tell me, and talk how they wanted to. I will, there was one person that talked about some past issues with those, but nothing current, and I did not ask specifically.
Okay, great. You mentioned the use of 3 interns. How did you find them, and what kind of training and background did they have prior to starting?
Well, we are an academic health department, and we have lots of interns, and we have sort of a pipeline for paid positions because we have 2 public health programs here in Tallahassee. So we got them through our intern program, and we kind of put the word out to faculty at both schools, and that's how we get folks. I think they had MPHs, most of them. Hey, let me ask. Roseanne is here with me, and she runs that program. So
most of them were working on their MPHs.
Yeah. So they were working on their MPHs.
And we do have some medical students and actually a freshman involved as well. So we do involve students as well.
Okay, fantastic. Another question we had is, this is a great study and very informative, lots of great information. Will there be a follow-up study to expand the sample size to include more individuals?
Yeah, so we're actually in the midst, what happened is COVID basically. So back in March, we wanted to do face-to-face. So at that time we switched to phone completely. And I actually kind of stopped doing interviews for a while and worked on the 9 that we had that I presented today. We put through some IRB amendments. We do 2 IRBs, so that's a barrier for us, is our institutions, our academic institutions, as well as the Department of Health IRB. So we just got approved for some additional COVID-specific questions. We figured now when we pick up interviews, people would have that as part of the conversation because it's part of every conversation now, but we really want to make sure we address it specifically, right? So we are going to expand the sample size, insert more COVID impacts, as well as the diversity of our folks, right? So not bending so much as a kind of higher educated, high income level. So yes, it's ongoing.
Okay, fantastic. Well, we are coming to the top of the hour, and I want to say a special thank you to both of our presenters, Dr. DeLeon and to Ms. Blackburn, for joining us today. It was a wonderful seminar. I would also like to take this time to announce our next seminar, which will be on February 9th at 10 a.m. Please check the Florida Health Grand Rounds website for upcoming information on webinars for the spring session and registration information. Thank you very much to everyone and have a safe and healthy holiday. Goodbye.
Thank you.